You're listening to Vet Synapse, a podcast connecting the world of research, innovation, and practical help to the veterinary profession. I'm your host, Dr. Philip Judge from Vet Education. Let's get connected with Vet Synapse. Well, welcome everybody to another episode of Vet Synapse. I'm Philip from Vet Education. Thank you so much for joining us for what I think is going to be a really interesting session today. Why is it going to be interesting? Well, the title kind of alludes a little bit to that. And the title of today's podcast is Hard Facts About Soft Skills. And to help me do that, I'm pleased to welcome Dr. Brian Faulkner. Now, just before I hand the microphone over to Brian and have a wee chat, I'm going to tell you a little bit about him because he's a really interesting and highly educated member of the veterinary profession. He graduated from Edinburgh Veterinary School back in 1995. He's worked in mixed practice, small animal practice. He studied an MBA. He studies a master's in applied psychology. He's also studied certificate courses in business and professional studies and small animal medicine. He's set up 5 veterinary practices. He's an honorary associate professor in veterinary business at Nottingham University. And in July of 2020 was awarded Fellow of the Royal College of Veterinary Surgeons in recognition of his outstanding contributions to the veterinary profession. That's not all. Brian's also a crazy runner. In 2017, he raised over £120,000 for the Brook Animal Hospital by running 10 marathons in 10 consecutive days, all across the United Kingdom and Ireland. And in August 2020, he ran 31 marathons in 31 days from John O'Groats to Land's End to raise $10,000 for a charity called Street Vet, which attends to dogs of the homeless. One of the reasons we have Brian along here today is that he's created with Kay Watson, his co-founder, an educational platform called Colourful CPD. It's a really interesting educational platform. Brian, welcome to the podcast today. I'd like us, if you could, to tell us a little bit more about your life as a vet and what motivated you to create Colourful CPD and a bit about what it's about.
Well, hello, Philip, and thank you for having me, and hello, everyone. So as you said, a 25-year graduate. You can tell from my accent that I'm not English. I grew up in Northern Ireland, a typical Northern Irish farm boy. Whenever I was growing up, aiming to go to vet school in the late 80s, it was all James Herriot. That's what I wanted to be. Come back to mid-Northern Ireland and do large animal, a bit of small animal perhaps. And 6 years of university in Edinburgh, I ended up going to the small animal side, and I did mixed practice for the first 5 years, but orientated towards the small animals. And then I locumed. I actually have worked in about 250 veterinary practices across my career around setting up my own. But in between those various little chapters of my career, so after 5 years when I left my first job, I then went and studied for an MBA. And why did I do that? The corporates were arriving in UK veterinary, very early stages, and I kind of thought, well, this is only something that's only going to expand. And I thought I probably need to know either what they know, either to join them or to compete with them. And I thought an MBA would be a useful thing to do. And it was eye-opening for me. It was entirely the first time I did anything non-natural science, and really like most of us vets, we're all biology, chemistry, physics. That's the way we do through school. Anything else is not even, as we said, proper. It's, that soft side of social sciences. And I think really with our scientific mindsets, why we think that is because we perceive it as less evidence-based. And that's one of the challenges. Sort of somehow, is it really real, or is it just common sense, or is it just psychobabble? Yeah, this sort of thing. So I did my MBA, and actually, weirdly, I think my MBA made me a better vet, made me a better clinician. And the reason why I say that is because I understood the concept of strategy for the first time. When you go to vet school, don't you? You get told a relatively specific technique to solve a relatively specific problem, and you go looking for techniques. Whereas in social science, of course, there's many ways to try and resolve inexact problems. And my MBA opened me up to that, and strategy was one of these ideas where you have multiple ways to get to a resolution, and actually you have to evaluate the various ones and then execute them, often in conjunction with other people. And that really helped my clinical work, both technically in evaluating options, as well as working with others. So obviously I used that as well on the genuine sense of setting up practices, and that was great. I really enjoyed doing that. I did serially of now number 5 current practice, and I work as a clinician. I think sometimes people, when they see my qualifications, they think, well, you mustn't be a real vet anymore. You mustn't work. I mean, I work clinically. At 10 o'clock last night, I was unblocking a cat urethra. And so, it's the same things that I've been doing for 25 years, just different versions of them. So I still work and struggle, if that's the word, with the everyday first opinion small animal veterinary practice. So after my first 3 practices, then when I sold them around that time, in fact, it was before I sold them, I did my master's in psychology. I was always really interested in why we human beings, me, myself as well, this sort of idea, why do we do what we do? Why do we not do what we do? Why do clients just not do what we ask them to? Why do I not do things that are apparently good for me? Why do I do things that are not good for me? And I just wanted to know more about that. That was always an interest, sparked again by the MBA. So I got the opportunity to do that. I was lucky. I went to the university in London and did a part-time master's in positive psychology. And that was, again, if I thought my MBA was eye-opening, the psychology was wonderful. So then I was trying to put this all together and trying to work out how to apply it to my own work and career, as well as maybe potentially helping others. And my journey began in terms of the whole non-clinical coaching thing. It began when I was actually attending, I think it was a cardiology CPD, whilst on a locum job. And the speaker got trapped in traffic and couldn't attend. And there was 50 people sitting in the room waiting for this cardiology, in which I was one. I happened to be just chatting to the speaker when the phone call came through and said, I can't make it. I'm trapped. The motorway is closed. And the speaker, or the organizer, turned around to me and said, oh my goodness, what are we going to do? Brian, can you talk about anything? As in, rhetorically, of course. And I went, well, I've just actually completed my master's and I've got some interesting stuff. I asked the question in my master's, what is a good vet? And I asked all the people who I thought might be entitled to have an opinion about that. And she just in her panic went, you're on. And I went, okay. And it was actually great because everybody in the audience understood it was entirely unprepared. It was more of a conversation, some of the themes that come out. And we can talk about some of those themes in a moment. But on the back of that, one of the participants, one of the audience members, practice owner, said to me, can you come and tell my vets that, please? And I went, okay. And he said, I'll pay you for it. And I was like, what, really? I got to get paid for this? This is amazing. So that's how that started. And I then chucked together a few slides. I like to make them relatively colorful. And I turned up and the practice manager said, so what's the title of your talk? And I went, oh, I don't know. We'll call it the veterinary consultation. And she went, oh, that's boring. Can't have that. And she looked at my slides as I was preparing them or getting them ready on the PowerPoint. And she said, oh, they're quite colorful. We'll call it the Colourful Consultation. And I went, okay, that's a bit twee, but we'll go with it. And that stuck. You talk about branding, that stuck. And people started referring to me as that Colourful Consultation guy. And because it stuck in one gig, if you like, led to another. And that's where it stuck. And so my original product was the psychology, the art, how to blend the psychology, the art, the science, the business, all of those components that involve a veterinary consultation and communication with clients regarding cases. How do you combine them in a way that kind of makes sense without being overwhelmed by a million theories, some of which, I know from my MBA, there's so many theories, you just go, they're so abstract. I just don't know what to do with them in my day-to-day work. They seem interesting, but I just no idea how to apply those. So I tried to work out a way where we could apply those many non-clinical theories into a model that made sense, that also was based around a thread of thought that vets would recognize. So vets, most are taught now, aren't they, the problem-solving approach to clinical symptoms and signs. So, we take our history, we do our exam, we form our problem list, and then we propose differential diagnoses as to what may be causing those particular clinical signs. And then where the strategy came in is I made more explicit this idea that we have really 3 strategies to resolve cases. What I call reactive, which is treat and see, treat what we think it is and see how we go. And that's 80% certainly in the UK of first opinion small animal practice. We treat what we think. It's 95, 97% of large animal practice. Or the proactive strategy is, okay, well, we know what the differential suspects might be. Proactively, let's try and work them out, either rule them out or confirm them, make it definitive, which is, of course, the proactive vet school way we're all taught to do it. But we know in first opinion practice, that's often we struggle to achieve that because of other variables beyond the textbook. And a lot of vets get, including myself, of course, I get frustrated, confused, uncertain with that sense that we're not really definitively knowing a lot of the time what we're treating. We're having to make decisions by people, clients, of course, who have to pay the bill, and they're quite entitled to have input about their pets. But often, as we know, they make decisions or have influences that we consider non-scientific and quite frustrating. So what the Colourful consultation model was, took that problem-solving approach to veterinary clinical resolution and then combined it with the consensus-based decision model. So we base it on science, which has to be, you have to have this history, exam, problemless differentials approach. And then we get to the what are we going to do stage. We know what our strategies are. I've just said reactive, proactive, and the third strategy was euthanasia. Of course, we can resolve clinical symptoms when we can't resolve them clinically or maybe medically, practically with euthanasia. And the client now has to, we're at a crossroads. The client now has to give us a green light effectively on the one. And then when I speak with the vets, there's a confusion sometimes about, well, am I allowed to tell them? Am I allowed to make a recommendation? How far should I push them? I don't want to seem to be pushy. I don't want to maybe take the responsibility for having been seen to influence. But at the same time, I know, and I help them a lot with that. And in a nutshell, I say to them, well, I don't think there's anything wrong with expressing your preference. So my preferred approach here would be to take an x-ray of blood, do whatever we want to do proactively, if that's what we want to do. And there's nothing wrong. Your clients come to us for guidance and advice, and we should express our preferences, but that doesn't mean the client has the right to veto it. And I always say they're not allowed to do anything that's immoral, unethical, or illegal. You know, they're not allowed to tell us to do something immoral, unethical, or illegal. And if they ask for that, we resist. But, you know, so many times there's okay, it's not ideal, it's not the preferred way, but we could probably live with that for a day or two and see, does it work? So it's helping people understand. I call that part of the consultation the consensus conversation. So we have to form a consensus. Both of us have to give a green light in relation to proceeding. So that's just a little insight of how the Colourful consultation works as an example. And that was my flagship product. And then when that became very popular in the UK, and I mean, one of the large corporates, every single vet was being put through that. Wow. And it expanded. I'm now speaking in Asia, for example, during the next month. I'm speaking in something like 10 countries across Asia. And there's this interest. So that's really the nub of it, Philip, is how do we try and combine science that's evidence-based, but in a way with trying to integrate a psychological process that deals with many of the non-clinical practical realities of veterinary practice, but in a way that actually is applying psychology that's relevant, and also through thousands of consultations now that I've observed is meaningful and evidence-based, you know. Right. So yeah, that's just an example of how that, and with Colourful CPD, so Colourful consultation then expanded into Colourful CPD, the wider company, and we now help the 4 roles in practice, so vets, nurses, reception, and management. We help those 4 roles with 4 outcomes: clinical, client, financial, and team outcomes, because everyone must contribute to those. And I think one of the challenges that people find with this is they sort of say, well, okay, when you ask practice, sometimes they say, well, yeah, we do that. The vets do the clinical work, and then the reception, front of house staff, they do the non-clinical customer service bit. And I go, yeah, but it's not fair or proper to try and ask a receptionist to resolve a dispute about money, which they, 1, didn't create, and 2, have really no power to resolve.
That's right.
And it's about how do you make that communication?
Yeah. And that kind of brings me to the next sort of question. We sort of titled this episode Hard Facts About Soft Skills. So why are these so-called soft skills perhaps not so soft at all. And I think you've alluded to that a little bit already. And to sort of backtrack a tiny bit, I think many of us go through veterinary school or perhaps desire to be veterinarians, hoping to work with animals and perhaps work less with people. And we end up working a lot with people, and not only our clients, but also our co-workers as well. And you sort of alluded to that a little bit in talking about, the receptionist and their role. And perhaps sometimes there are things that they are dealing with that are not of their own creation, and that perhaps other team members may be able to help them out with, through better consultation, communication, and those sorts of things as well. So why are these soft skills not so soft at all, Brian?
Well, ultimately, if you look at the outcomes in relation to a good clinical experience, or if you look at the outcomes that I studied during my master's, there's 4 outcomes in clinical practice that need to be satisfied to keep most of the people involved happy. So clinical resolution, of course, that's what we do. We're vets and veterinary practices. We're there to resolve animal clinical problems. So that's a given. But that's not enough. If clinical resolution equaled client satisfaction, i.e. if we got the pet better, clients would be happy. And this is sort of that implicit assumption. But we know that we can do great work and yet have a complaint or a moan from a client. Mm-hmm. And what's that about? Maybe how it was done, how it was communicated, or certainly money. So the reality is, if you look at client complaints to veterinary practices, 80% of those complaints, when you track back why it originated, 80% of them have nothing to do with the clinical decision-making or competence or technicalities. They're to do with the client understanding expectations, money, the experience. So the first reality why they're not soft and therefore important is because they're the ones that hurt us. They're the ones that make us angsty. When clients complain, it's uncomfortable. When colleagues dispute things, it's uncomfortable. So it doesn't feel very soft when you're at the sharp end of a client shouting in your face about something, even though often we think we've done a great job. Mm. So it's not soft. And the reason why we refer to them as soft is because we can't necessarily prescribe them as specifically as what we might do, for example, a TPLO operation. Mm-hmm. We have to. They're much more based on principle, and this is where the challenge is people often say, well, where do you start? You got to kind of have a few basic principles well integrated. It's a bit like us doing surgery. You got to understand anatomy and physiology, and then Halstead's principles before you start doing specific procedures. Yes. And if you got your Halstead principles, we know we can more or less do most things. And that's really the level with these softer skills, is we have to understand, for example, the anatomy of confidence, as I call it, mm-hmm. the pathophysiology of self-doubt, and the principles of resolving disputes. So, and if we understand these principles, then we're better. We know different personalities, moods, and everything make variants. We know that. There's no one way for me to say, let me tell you how to tell an angry client to stop shouting.
Wouldn't that be great?
Yeah, exactly, wouldn't it? Okay, do A, do B, do C, it'll be stuff. However, we do know what works most of the time. So we know, we all know, I'm sure, theoretically, that when we've got an angry client, we listen to them, we don't interrupt them, we let them blow themselves out. And we that doesn't mean in a dismissive way, is that anger is an emotion that is stimulated by a sense of injustice. So, or obstruction. They're the two things that cause anger, injustice and obstruction. And if we understand those and we try to identify the injustice or the obstruction in their mind, which may be real or perceived, we can then go, okay, so you perceived it was unfair that I told you it was going to be £500 and then I charged you 100 or 1,000, pardon me. I told you 500, but somebody charged you 1,000. Okay, so I see your point. That might seem a little unfair.
That's right.
But, and when you see the vets and they go, but we had to do all these things, and the client goes, I know, but you told me 500. Yeah. That's what I thought. Mm-hmm. So, for example.
Yeah. And managing expectations and being able to allow that client to articulate the reason why they're angry. Yeah.
And that just brings me to the crux of communication. All the time I'll see people referring to, oh, it's a communication problem. Like somehow that's a diagnosis. It's a bit like saying, oh, the animal's sick because it's an orthopedic problem. Like, oh, okay, is that I got it now. You know, and you kind of go, well, that's a bit vague. So communication is the ability to set, confirm, and adjust explanations and expectations. And that seems like a mouthful and takes a wee bit of getting your head around. But setting an expectation, adjusting the expectation if it's not as we turned out, or confirming it and go, okay, we thought it was X, as it turns out the X-rays confirmed it's X, okay? Or explanations. Let me tell you why your dog's vomiting. There are various suspects, and actually here's the suspects' explanations. So clients want to, because human beings do not like uncertainty. And one of the biggest principles, if there's one psychology principle, the only psychology you ever need, is if you manage someone's uncertainty as best you can, or at least acknowledge it and manage it and say to them, I understand you feel uncertain. I'm doing everything I can to try and contain or resolve that uncertainty. And you communicate expectations and explanations, you're more than halfway there.
Absolutely.
And that is such a useful principle.
Yeah, that's great. So this all sounds very logical and very sound. And I've looked at some of your courses in Colourful CPD, and they do follow a really nice, sound, logical approach. And as a veterinary scientist, it makes a lot of sense to me, which is, I think, is why what you're talking about appeals to so many people. But there's still quite a few people who find this sort of stuff challenging to firstly approach and get their head around, and secondly to try to manage when they're on the floor dealing with a situation with a colleague or a client, or interdepartmental communication within a larger veterinary hospital. So what are some of the greatest challenges that you see people face in trying to improve these skills to try to make their life a little bit easier?
The biggest ones, I think, are trying to get principles and practices that are contextually relevant. You know, we've all watched, I'm sure, we're inspired by TED Talks, and we find it interesting, and we kind of go that, and we're all, as scientists and practitioners, trying to squeeze that model into how does that apply. Right? Both, we're kind of going to work it out. But if you make, it's a bit like doing surgery. If you put a lot of different techniques together because you thought they're quite useful, but there's no coherence to your contextual situation, you've just got a mishmash of inconsistency. So that's one of the challenges. People say to me, where do I get started, and where do I get started, and where is it useful to me as a veterinary nurse, for example, doing consultations, as a veterinary receptionist having to deal with clients, as a veterinary surgeon having to deal with clients and all the moods and affordabilities, with managers trying to deal with colleagues. In fact, I'm about to give a talk today on how to have a quiet word as a manager, how to have a quiet word. Let's not make a mountain out of a molehill, but there's something that maybe needs a quiet word. And we understandably get very nervous about confrontation. We don't want to overblow it, but we don't want to ignore it either. But where on earth do you start? These are risky conversations because they involve uncertainty again. How is this person going to react? So the courses really are all based on context. They're littered with contextual examples of what it's like to be a vet, nurse, reception vet, or manager. And they're the challenges. How do we understand these principles? Where and why are they relevant? And how do I apply them to the jobs that I do on a daily basis? And that's what we've tried to do in the online courses.
So you've got a lot of great content, as I've already mentioned, on your website, Colourful CPD, and you've alluded a little bit to some of that content, but I'm just wondering if you could tell us a little bit more about how this content can overcome some of the challenges that you just mentioned, so that oftentimes it's, how do people get that contextual relationship between, say what you're talking about, which sounds really logical, how do they get that contextual relevance to their own practice?
So yeah, a lot of them we base on situations, so situational responses. Again, I'll give a veterinary example. So one of the things that took me, I think, 20 years out of my 25 years to really explicitly realize is when we do a history, clients tell us what they've observed, and we all have been taught how to do histories. We do a clinical exam, we got our problem list. And at this point in the consultation, feelings of uncertainty are inevitable. And there's uncertainty about what's causing that cough, sneeze, vomit, limp, scratch, lump, diarrhea, because our physical senses can only tell so much. we can wiggle lumps till we're blue in the face, but it ain't going to tell us what that lump is.
No.
We'll all guess it feels like a lipoma right up until it comes back as a mast cell tumor and we're all surprised. So one of the things I've realized is uncertainty is inevitable. But what we find, and I found, and many vets I coach find this, is that uncertainty, or put another way, doubt, is we turn that doubt that's situationally inherent into self-doubt.
Mm-hmm.
We go, I'm not sure. And the answer is because it's not knowable at this stage without further investigations. But there's nothing wrong with that as long as we have a clue of which possibilities it could be and how to resolve them. But we often do this, I'm not sure, conclusion, I'm not good enough.
Mm-hmm.
A better vet than me would know what that lump is, whether that cruciate's really ruptured, what that abdomen feels like. All these sort of things that are, yes, skill, but at the end of the day, we know uncertain. So what I help them do is just take them through the journey of the process and then give them those moments of saying, I suspect at this moment, this is probably what you feel.
Mm-hmm.
And you're probably thinking it's me. It's my inabilities, inadequacies, as opposed to going, well, actually. And people say to me, they email me and say, oh my goodness, I've been struggling for 20 years with that. I just never thought that it wasn't knowable explicitly. And I struggled with it in the sense of I just always thought it was me. And I went, yeah, I used to do that. And once I realized, it enabled my communication with the client to be so much more precise, actually, or more fair. I used to say, okay, Mrs. Smith, we've got this problem. There are various suspects. There's not a vet in the world that can tell you on the information we have right now what's causing this. Mm-hmm. And that was such a releasing phrase because it used to be, it's not just me. You're not just wasting your money on me. There's not a vet in the world. And anybody, I wouldn't say this, but any other vet that pretends they know what that lump is by feeling it is deluding everyone. Mm-hmm. But it's this, I kind of say, so actually however, there are some very relatively simple ways we can proceed here. With a lump, I say, you've got three options. We either ignore it, we do a needle aspirate of it, or we remove it without really knowing what it is. I said, technically, there are options. There's risks and benefits to all of those. And we're giving much more neutral advice. Mm. And then the client will say, well, what would you? I say, well, I'd prefer to pop a needle in it and suck a few cells. And there's 80% probability that we'll find something useful there. It's not 100%, but it's a pretty decent, relatively cheap, non-invasive test. And so we're understanding the neutrality of the language without, and I find a lot of vets are worried that their reputation, their responsibility is on the line when clients ask for their opinion or expect it. And the vets are going, oh, what happens if I'm wrong? Well, that's one of the things I've learned is you don't have to get cornered into saying, this is the right answer. This is an answer. It's got pros and cons, but this ability to be able to say, here's your options, 1, 2, and 3. And also a little thing of psychology. Human beings are very good at remembering 3 things. If you give them more than 3 things, they stress. Yes. So it's helping clients through those conversations. So that's what the courses do. They talk through situational things. They give lots of veterinary specific examples, not just for the vets, but nurses, reception managers.
Excellent. That all sounds really, really good there, Brian. And I think, you've alluded to quite a few things there. And obviously, veterinary nurses and receptionists have their own series of issues and problems as well. I understand that your courses go through the sorts of communication issues and or communication scenarios that they may face with clients as well. A lot of what you were talking about, I think, is particularly relevant to a lot of vets in the younger generation. It's not that older vets, such as myself, I think I'm older than you are, but maybe not. But so the vets have been out of university for a number of years. Oftentimes we've got life experience. We've made a lot of mistakes in our lives. We've learned to cope with things. We've learned sometimes by trial and error, sometimes mistakes along the way, how to communicate well and how not to communicate well. But as you pointed out, sometimes there's a light bulb moment that occurs 15, 20 years after you graduate and you think, my goodness, I wish I'd known that earlier. But we have quite a lot of really highly stressed younger members of our profession who graduate, I think, sometimes with this expectation that, armed with the knowledge they have in veterinary schools, that they should have all of the answers. And I think compound that with a stressful client, or perhaps new relations with veterinary staff if they're starting a new job, and that can sometimes really mount up and become, a perceivably insurmountable amount of stress for these people. And sadly, some of our professional members, commit suicide, and it's a big problem in our profession. So I like what you're talking about here, to try to contextualize some of these issues and to empower people to be able to communicate better with their clients and their colleagues, while introducing the only thing that is certain in psychology, which I'm sure is uncertainty in the people, which is what you said, is that we have no idea how somebody else is going to respond to something we say, and we may have a client in our consultation room who has lost a family member or lost another pet, or they're dealing with financial issues or illness, and we have no idea what's going on. We can say, your cat has got a blocked urethra, and they may have a complete a reaction that is not understandable immediately to us, a stressful outburst or a fit of aggression or something like that. So helping people through this is really, really helpful, but I also think giving people the tools to understand what they can achieve in a consultation as a professional without necessarily having to name the disease and get it right every time, I think is really helpful.
Absolutely, yeah. And you make various points there. Just out of interest, in the UK, we find that there's a spike in complaints at the 25 to 30 year graduate stage. I think complacency kicks in, probably boredom, probably distraction. CPD may not be quite up to date as much as we perhaps could be with some. And there is this element of, if you think of the half-life of knowledge, I think in veterinary, probably the half-life's about 15 to 20 years. In 15 to 20 years, half of what we thought was causing what, or how we resolve it, is now obsolete. It's just which half you don't know. And so CPD, of course, for that. So you do find that those become exposed later. And interestingly, in the UK, we talk about the old guys, and the danger of becoming this guy is the jab and go. The jab and go. It's you jab and go. You treat and see. The clients trust you because you've got that track record of credibility with them. We look like we know what we're doing. We're a bit grey. We're a bit wrinkly. And whenever you've got the blonde, fresh-faced younger person, one of the challenges they often say to me is clients just don't believe me. They doubt me. And interesting, when you get into the psychology, that's a very common coaching session I have, is I say to them, actually, the biggest problem in the nicest way is you doubt you. I don't say that straight off the bat, but that's where we get to, and we realize they doubt you. And I said, if you had more conviction, you would find that the clients, but I don't mean conviction through aggression, because that's what happens. And you see sometimes is when the client pushes back, that resistance can often precipitate maybe an aggression or a snappiness back in us because we don't like being doubted. And therefore, then we lose the rapport with the client. So it's how do we deal with that pushback, which is inevitable, but in a way that comes across as assertive, but yet not certitude. And that's the balance. And just the other theme you said there, Philip, is my little stress equation is stress in any context in life, not just veterinary clinical work or practice or anything. Stress equals uncertainty multiplied by urgency.
Yeah.
I don't know what's going on or did go on or is going to go on, and the clock is ticking. And that clock can be as simple, it can be a clinical clock, a GDV is a very urgent clinical case, or it can be the client clock where they're looking across the table at you, almost tapping their fingers going, well, and the panic that can create in a person who's not sure how to cope with that urgency creates stress. And so we talk a lot about that in the courses, these sort of examples. And but you're right, learning these skills early, if we get them early, and maybe I'm being a symptom of my own advice here, is that the other disease, I call it a disease, the other symptom we see is over-explaining.
Yes.
We're pathologically addicted to over-explaining. And the reason why we do that, and I'm probably doing it here, is the reason why we do that is because we're so desperate to persuade and convince the client. We know what we're talking about. We say too much.
Absolutely.
We tell them too much.
Yeah. And I found the older I get as a veterinarian, the shorter my explanations get about the conditions that an animal has. And I often relate to veterinary students when I'm teaching my conversation about gastric dilatation volvulus, which is what you mentioned before, is extremely short. It's a matter of 5 or 6 sentences. And the client then has this really simple overview of what's going to happen with an opt-out that I might call a client in surgery if there's something really urgent that I need to talk to them about. Whereas it's quite tempting, I think, when you're a little uncertain of yourself, as you mentioned, some particularly more recent graduates are, but it can hit you at any time, then to sort of over-explain things and to talk about gastric necrosis and the fact that, if the left gastric artery is damaged, then, that can be a terrible thing. You can lose the distal esophagus. And as a client, when you're hearing that, it's all just bad. And, whereas these things may not be happening in the animal, but some.
And the motive, Philip, for saying that is whenever you see it also in clinical notes. Clinical notes are written like some sort of expert witness statement. And I say those conversations that you've referred to as, the lining the arteries and all that, is the motive behind it is that we basically go, well, I want to be able to make sure if I have to ever stand up in court one day, I can say, I told them so. Mm-hmm. And it's a defensive strategy. That's actually what's happening there, as opposed to saying, okay, definitely you have to have informed consent. We know that. You have to be able to understand the risks and the benefits, the pros and the cons, the probabilities of success and failure. But I think when we become a little bit clearer of understanding that we're not in a viva, we're trying to give an average, honest pet owner honest advice. I always speak to clients like they were my mom. That's kind of always my. Whenever someone says to me, what would you do if it was your dog? I sometimes answer that straight off the bat with what I'd do if it's a clear-cut case. But most of the times there's uncertainty. And I go, let me tell you what I would say to my mom. If my mom was asking me that question, what would I be saying to mom? She knows I know a wee bit more about dogs and cats than hers, a wee bit maybe. And she also, seems to quite like the dog, so I suppose I better look after it. And there is this element of what would mom want to hear in a language that she understands, and that's the sort of guidance I tend to. Now, obviously, sometimes we get moms who turn out to be very qualified pediatric surgeons or something like that, then we have to change our tone, don't we? But you're right. That over-explaining. But it's often motivated with a defensive mindset because we're terrified clients will say, but you didn't tell me that.
Yeah, that's right.
But it's about how do we pick the appropriate amount of knowledge or information to help this client in a way. And I just did on that theme, one of the little things, I go, a consent form is almost like a wedding ceremony. I've even said this to clients. I kind of go, not many times, but I have said this to some clients. I've said, you know what? So we decide to do this, for better, for worse, for richer, for poorer, in complication and death, we proceed. And I've said, that's what we're doing here. We're making an agreement to deal with what comes. And I've got a commitment to that agreement, and so do you. Rather than say, and I don't say that all the time because it just sounds weird, but it's that mindset. It's that mindset that says we're making a consensual agreement here. And I don't know what's going to happen, but I am going to tell you, I'm going to give you my best out of it. And I need you to understand that I need you, a phrase I'll use a lot, is that I need you to hold your nerve if things aren't quite going to plan.
And oftentimes view the role of our communication with clients is a little bit like going around that feedback loop. We start off with a need for procedure X, Y, or Z, expecting a certain response, but we do need to repeatedly communicate with our clients and our colleagues and managers about stuff that's going on with the patients or with their communication. If we see communication going off the rails to some extent, or a client becoming dissatisfied, or one of our work colleagues becoming dissatisfied with the way things are going, we do oftentimes need to go back to the home base and sort of reevaluate those things. How do you suggest going about that?
Well, yeah, it comes back to that principle I said earlier. Communication is about setting, confirming, and adjusting expectations.
Yeah.
And, many examples, but it starts off with making sure that we're on the same thread. The recheck consultation is another example. Is I always begin any recheck consult, even my own, but especially one that I didn't see the primary consult, by reading the notes out explicitly to the client to make sure that we're on the same page.
Mm-hmm.
And therefore, I've set the expectation of this is what you think, this is what the vet thought. Okay, that's fine. So how are we getting on now? Yeah. And then whenever they say things, is that we make sure that we were on the same thread. But it's a version of what you've said. Those feedback loops are constant setting, confirming, and adjusting expectations. So bills, money is the classic example. We give an estimate. An estimate. And I suspect your computer systems are similar to ours in the UK. We do them based on billing up the item, and it comes out to what, if it all happens, this is what the bill will be. Yeah. And it comes out. So Mrs. Smith, it'll be $763.29 approximately. Approximately. Give or take. And as clients say to me, whenever they get handed their estimate to 2 decimal points, they go, Brian, that doesn't sound rough to me. That sounds pretty precise.
Pretty precise, yeah.
And I go, well, it's just the way the computer makes it. But it's that sort of idea. But in other words, when we report that bill to the client, and I do this after every operation, I have a PPP formula. P is for pet. Mrs. Smith, hi, it's Brian the vet. Just let you know, Scooby's fine. They relax, don't they? They listen to you. Second P is process. This is what we did. This is what we found. Blah, blah, blah. Mm-hmm. And then the final P is price payment. And I say to them, okay, just to bring you up to date with the account, we estimated it would be 750. It pretty much went as planned. Your bill right now is 750, more or less. And so I tell them, I confirm the expectation. Mm. And if it turns out to be 900, the worst crime, I call it a crime, we could do in the world is just hope they don't scream at reception at 5 o'clock when they come to pick it up. I think it's massively moral, ethical to clients, reception, and everyone to say, Mrs. Smith, we said it was about 750. As it turns out, we did a few things that we didn't expect, but this is why we did them. And just let you know, your bill is 900 now. Mm. Is that okay? I always say, is that okay? People say to me, what do you do if you say it's not okay? And I go, well, I'd rather deal with it on the phone than 5 o'clock in reception.
Absolutely. Yeah.
Yeah. Is that okay? And 99% of clients in our world will say, that's okay, Brian, as long as he's okay.
Yeah. Yeah. That's right. Yeah. Brian, it's been an absolute pleasure speaking with you today. I want to thank you for taking time out of your very, very busy schedule and to share your thoughts with us on hard facts about soft skills. I think there's a lot of really useful information in there. So thank you so much again.
You're welcome, Phil. And probably we should mention, maybe should have mentioned earlier, is that we're doing a half price promotion in Australia, aren't we? We're doing, so literally our course is just as an introductory flavor. We're doing half price on everything, just so to see what folk think of it, and hopefully they'll find it useful. Thanks for listening, everyone. I hope you find it useful, and plenty more where that came from.
Thank you again, Brian. It's been an absolute pleasure. Keep safe until we meet again. Thank you, everyone.
Yeah, thank you, and goodbye, everyone. I appreciate your time.
Thank you for listening to this episode of Vet Synapse. If you like this episode, please subscribe to the podcast and share it with your friends and colleagues. Make sure to visit our website at veteducation.com.au for more great content and to experience the latest online race-approved veterinary continuing education.